to the Gastro Echo session. G-Echo is hosted by the Gastro Foundation in association with Project Echo, University of New Mexico. These sessions are held weekly on a Wednesday, and the chat will be open for questions, so please leave your comments below. Today I'll be presenting two cases, interesting cases that we've received at the Donald Gordon Medical Clinic in the last couple of months. Let's start with the first one. So the first one's a 15-year-old female that was referred to one of the pulmonologists at one of our referral centers. She contracted COVID in 2022 and over a few months had progressive worsening dyspnea, was referred to a pulmonologist, at which point they found large ectatic, massively dilated pulmonary veins with pulmonary thromboembolic disease. At that time, she had a mildly abnormal liver function test with normal bilirubins, an alkaline phosphatase of 75, gamma GT of 18, an ALT of 30, and an AST of 50. But of note, ammonia was done, which was slightly elevated at 71. Her serum albumin was 27. She had normal platelets, no ascites, no other features of portal hypertension. But of note, she was noted to have delayed milestones growing up. She had failed 2 years in primary school, and imaging done at the referral hospital was quite discrepant. But between the CT and the ultrasonography, they were convinced of aberrant portal anatomy. So formal portal venography was done, which showed a portosystemic shunt with the portal vein entering the anterior aspect of the suprarenal IVC, with unfortunately no demonstrable portal vein. This then confirmed the diagnosis of an Abernathy type 1 malformation. Liver biopsy was performed just to see and assess the liver parenchyma itself, but also to check for evidence of intrahepatic portal venules. Over to you, Prof. Hale.
Right, thanks, Dr. Parbhoo. So, as you have said, we got a liver biopsy, and I'm going to show you the pathology, which is actually an interesting pathology because to begin with, it just looks relatively normal. And I think that history is very, very important. So I'm going to share the screen. Okay, so this is the liver biopsy. Can you see that? Everybody see that okay?
Yes, we can, Prof.
That's shown. All right, so the first thing that becomes immediately apparent is that the architecture of the liver looks all right. So you could potentially pass this off as normal, but I think the history is very important, and there's some subtle changes. I'm not sure if there are any histopathologists in the meeting, and they will probably know these changes. But if we look at the structure, we can see that here we've got a portal tract there, we've got another portal tract there. And when we go down and have a look at these portal tracts, you can see that that's better. You can see that the portal tracts are, I think, normal in size. We've got bile ducts represented, and we've got hepatic arterioles. For example, here you can see the bile ductular structures. There's a bit of ductular proliferation at the periphery. That's the hepatic arteriole there. And I think that could be a portal vein. And at first glance, I think you would pass that off. But as you go down the portal tracts, you can see, as you go down the biopsy, there's another portal tract. And I think that you've got the artery, you've got the duct, and I think that's probably the portal vein there. And then you get to other triads. such as these here, where there seems to be an absence of the portal vein. Now, the other thing that we've also got in this liver just to orientate you. Sorry, I'm moving around a bit so I can show you the sort of telltale signs. So there's a portal tract, there's a portal tract, and this is zone 3. And what we've got in zone 3 is we've got dilatation of the sinusoids, but also in some areas we've got atrophy of the hepatocytes. And that atrophy is variable. So for example, if I ask you just to take a mental photograph of this area here, and if you look at the width of these hepatocytes here, so there you've got 2 hepatocytes next to each other, and you can see that they are relatively small. So take a picture of that in your mind, and then when we move to zone 1, you can see that the zone 1 hepatocytes are considerably larger. It is subtle, but if we move down to this part of the biopsy here, you can see here straight away that we've got hepatic atrophy, liver cell atrophy there, which is, I think, pretty clearly demonstrated. These hepatocytes maybe not so, but you can certainly see that there is this sinusoidal dilatation or apparent sinusoidal dilatation. We don't have a portal tract to refer to in this particular field other than to suspect that there may be a portal tract right at the edge here. So here you've got this extensive hepatocyte atrophy, and I think otherwise this liver biopsy is pretty bland. But it's this sinusoidal dilatation and the hepatocyte atrophy that I think is the clue to the diagnosis. There's another portal tract there. It is variable. Here you can see that you've got the artery, and I think the vein, it's not the vein, the bile duct I think is next to it, and I think you've got another hepatic artery there. But the portal vein is conspicuous by its absence. Here, next door to it, you've got, I think, a greater representation of the structure. You've got a hepatic artery, a bile duct there, portal vein there, and the hepatic artery there. Now, bearing in mind that we've got this hepatocyte atrophy, that is the clue to suggesting, in fact, that there is impaired blood flow. Because what happens is as the blood goes down, as we know, we've got the entry of the blood into the liver is mixed. Got 40% or so coming through the portal vein, the rest coming through, 80%, 40% or so coming through the hepatic artery, but about 60% or maybe a little bit more coming through the portal vein. So when you have obstruction to either the hepatic artery or indeed the portal vein, you get ischemic changes taking place in the zone 3 hepatocytes, because you've heard me say before, the zone 3 hepatocytes are the hepatocytes that, if you like, are living on the edge. Those hepatocytes are the ones that are most vulnerable to any injury, whether it be toxic injury, ischemic injury, vascular injury. So those are the hepatocytes that undergo atrophy. Compensatory hypertrophy happens in zone 1 hepatocytes because they are better supplied with blood, and that is thought to be the mechanism for what we know as nodular regenerative hyperplasia that occurs in a subset of patients. So from this point of view, from this particular patient, patients, for example, with portal hypertension or portal vein thrombosis, if they have obstructive flow into the liver, in fact, the changes are really pretty nondescript. And it's only really, for example, that one sees portal vein thrombosis in liver biopsies that have been undertaken in patients with that particular entity. So really they are really uninspiring biopsies to look at. However, in this particular instance, I did a CD34, and the CD34 is a good immunohistochemical stain for vessels. I just want to, sorry, before I show you that, I just want to show you the H&E on the second block. And it shows similar changes that I showed you earlier on. So if we look, for example, at this portal tract, you can see that there's an absence of the portal vein in that portal tract. And if we look at this portal tract here, you can see once again, it's a little bit messy, but I think there's a bit of spindle cell proliferation, and you have these very small, thin-walled blood vessels, and those are really just aberrant vessels that develop in the portal tracts in an attempt to carry the blood. But you can see that in this particular portal tract, there are no portal veins of any significance. Right, so now I'm going to go to the CD34 on this particular biopsy. So this is on the second block that I showed you. Right. So there is a portal tract. And what we've got, this is a portal vein, which is staining up nicely, the endothelium. And you've got CD34 positivity in the zone 1 sinusoids. And that's actually spot on. That's exactly what one should see in CD34 staining in the liver. Now, this CD34 stain is a particularly good stain as well when it comes to identifying hepatocellular carcinomas. And I know it's a little bit off the topic, but CD34, at least in hepatocellular carcinomas, you get a change happening in the sinusoidal network in malignant tumors, and that we call the sinusoidal network undergoing what we call arterialization or capillarization. And what happens is that the sinusoidal expression of the epitopes changes. So in hepatocellular carcinoma, in benign liver, what happens is that you get differential staining, and you can see that well demonstrated here. So you only see CD34 positivity in the zone 1 hepatocytes or the zone 1 sinusoids, whereas the rest of the liver is normal, or negative, I should say. So in hepatocellular carcinoma, what happens is you get extensive sinusoidal positivity. So that's by the way. In this particular instance, I wanted to show you this here, because what you've got, as I said, is a typical CD34 picture where you get the portal vein being picked up and the zone 1 sinusoids. Now, if we go to the other portal tracts, for example, there's another one there. So we're using the CD34 staining then in zone 1 as a surrogate marker, for example, of the portal tracts. And if we look here, we can see there is a portal tract. You can see the bile duct, I think, which is just poking its nose through. It's extensive CD34 staining in the zone 1 sinusoids and a complete absence of the portal vein. And that picture is replicated in the other portal tracts. Every single portal tract, or the majority of the portal tracts, show an absence of a portal vein. And there you've got two portal tracts, no obvious portal vein demonstrable. I think that's probably another one there. And I think that's the portal vein there. And in the rest of the portal tracts, no significant portal vein. And there's a nice example here. You can see, for example, in this particular portal tract, you can see the bile duct, and you can see the CD34 positive staining in the zone 1 sinusoids. So it's a good example then of agenesis of the portal vein or Abernethy syndrome. And yeah, it's a good example. You don't often see this. There's another one there, and you can see the bile ducts represented. If I bring this here, you can see the bile ducts there, but a complete absence of a portal vein. Turn it over to you.
Thanks, Prof. So unfortunately, this young lady, the only option then would be a liver transplant at some point, but due to her current pulmonary vasculature, she'd need a combined lung and liver transplant. She seems to currently be doing well on dual pulmonary artery hypertension therapy. At the moment, her ammonia is controlled on lactulose and rifaximin, and unfortunately, from chatting to the transplant surgeons, both on the cardiac side and our side, is that due to this very ectatic pulmonary vasculature, the only way to do a decent transplant would have to be an en bloc resection of heart, lungs, liver together with the great vessels, which if she needs it in the future is going to be a bit of a problem. We haven't done one of those in South Africa. So for now, we're aiming to keep her symptom-free and functional, just because a big transplant like that would also run a higher than normal transplant-related mortality. So yeah, we were actually kind of, the initial scan and the reason for the biopsy was that she was actually initially reported as a type 2 Abernethy, which in that case, just closing off the shunts and forcing blood flow through the liver, as long as there are demonstrable intrahepatic portal venules, is an option. And then it's a completely treatable, reversible cause, as long as there is a good extrahepatic portal vein and demonstrable intrahepatic portal venules. But that's type 2. Do we have any questions at this point, guys? I don't see any in the chat box. So let's
Dylan,
move ahead to case.
Yeah,
Sorry?
Dylan, could I ask you, that's an interesting point, you know, are there demonstrable portal radicals? So I think the question also I would have is that the portal radicals are not visible because there's no blood flowing through them, or minimal blood flowing through them, and consequently they won't be, you know, that visible. Is it possible to cannulate the portal system in the liver, intrahepatic cannulation, and do a venogram within the liver?
So, Prof, from my reading, the agenesis, or the, I don't know if I'm using the correct word, but the absence of the portal veins is not a single entity, it's more of a spectrum. So each case that's been reported of Abernethy 1, some have had hypoplasia and some have had complete absence, or some along that spectrum of having some but not all, or small portal venules but not decent sized portal venules. So it's sort of individual case by case, but when they do the balloon occlusion of the shunt and inject contrast, they're looking for some level of sliver through where the main portal should have been, going towards and entering into the liver. And unfortunately, this case, there was none. So it looks like we've had agenesis in this case of the extrahepatic portal vein. But
Okay.
yes, that is the game, that is the logic behind doing the venogram, that you try and get some contrast seen flowing towards the liver and into the intrahepatic portal system.
But if you had, for example, let's say you had a a portal vein web, for example, you may not get it through, but there may be something on the other side of that obstruction.
But you'd see it on a CT scan then, hopefully. You'd see
Well,
a vascular structure, hopefully.
yeah, sure. Yeah. Yeah, so she's very difficult.
Yeah.
Okay, thanks.
Okay, Prof, shall we move on to our second case?
Yep.
We've got a 54-year-old female, Miss JH, who's a background type 2 diabetic with a HOMA of 6, A1C most recently of 7.5%. Had an elevated BMI for most of her adult life, current sitting at a BMI of 30.4. She's had no significant ethanol use and no other risk factors for secondary causes of steatotic liver disease. Was referred to our unit to one of my colleagues as a NASH cirrhosis or metabolic associated steatotic liver disease patient with cirrhosis. She had already had episodes of ascites, at least 4 episodes of hepatic encephalopathy. She's had hypersplenism with a spleen of 17 centimeters in size and had a previous liver biopsy, which was just reported as macronodular cirrhosis with steatosis. But of note on her evaluation tests, her alpha-1 antitrypsin level was very low at 0.2. So we had sent the biopsy to you for a review just to see if there was a concomitant etiology on the biopsy.
Thanks, Dinen. When I saw this case, I was quite amazed, in fact, how patients can slip through the net. When was she first? When did she? I mean, what was her sort of childhood history and that sort of thing? Dinen, do you know?
If she was Dr. Bowett's patient, if you give me a sec, I will have a quick look.
Because
So
yeah.
I don't have much about childhood, but she did secondary, tertiary education and qualified as an accountant. But not too much else on the younger history, Prof.
Yeah, because I mean, my impression when I looked at and reviewed this biopsy, it was in fact that this was almost the sort of, I mean, at the age of how old? She's 52, is she? I think.
Yes,
Yeah, she's
54.
52, 54. And I was actually quite stunned that that somebody could present so late with this entity. So this is the biopsy. Let's share my screen. Now I've got to find it.
So Martin, I mean, you would expect the liver disease to have presented much earlier.
Well, also you'll see, Chris, that I mean she's really got advanced. I mean she has cirrhosis, and this is not just sort of gentle cirrhosis. This is severe cirrhosis. I mean, cirrhosis, as we know, is an end stage disease, but she's had these episodes of encephalopathy. So this is the biopsy, and you just minimize this. Right, so this is the biopsy. Can everybody see that?
Yeah.
Okay, thanks, Chris. So here you've got pretty scrappy biopsy. And I think that really what we're seeing is the effects of cirrhosis. And you can, if you look at this, you can see really advanced cirrhosis. We've got these small regenerating nodules, and they are surrounded, as one gets with cirrhosis, this dense inflammatory infiltrate, and we've got nodules, small nodules of hepatocytes. And in fact, these nodules of hepatocytes almost look as though they are small nodules that are entrapped in fibrous connective tissue bands. And you go through this and you have a look, and what we see is this sort of picture here. And I am focusing on it in the interests of time, and one's got to have a sort of a careful look at all these sort of things. But if you look in these hepatocytes, you can see that they are distended, and you've got these pale bodies in the cytoplasm, multiple pale bodies in the cytoplasm, and that picture is replicated in other areas of the biopsy. Possibly not as well. Let's see if we can find a few. So this sort of thing, isn't there another couple there? And you look at these and you say, geez, what's going on here? And but when you've got a woman of 54, the last sort of thing that you're thinking of, well, you don't want to think of, is alpha-1 antitrypsin deficiency, because it would be extremely unusual, I think, from I know adults present with alpha-1 antitrypsin deficiency, but to present this late. And I think it also came at a time where we also had another patient, completely unrelated. This was an 80-year-old man who presented for the first time with celiac disease. And I couldn't believe that at the age of 80, you'd seek advice for your chronic diarrhea or your malabsorption. And he certainly had celiac disease. And these two patients really arrived at the same sort of time. So it was a case of sort of late presentations of two very interesting entities. So there's a bit of steatosis, as we heard, large droplet steatosis and small droplet steatosis. And there's also some nuclear glycogenation as well, this sort of thing that you see there. So we need to get to really where the money is. And if I remember correctly, I don't think she had an increased BMI or anything like that. And I think the steatosis is a manifestation of the alpha-1 antitrypsin deficiency. So we're going to stop that there. And I'm going to, something's happened. I've just got to change around. This is a consultation, so I had to send the original slides back to the practice concerned. So these are scanned images. So this is the same nodule, that same small nodule. And I think I've got to stop the share. I think I've got to share the screen again. Right, you should be able to see that image now, Chris.
Yeah.
It is coming up, Prof.
Great, thanks. So this is that same nodule. And lo and behold, there are the globules. And
Lovely.
it was really amazing. And believe it or not, this was overlooked at the time of the original biopsy. And you've got these globules of varying size. I mean, these are massive, and small globules there. And you look at this and you say, wow. I mean, this was really a wow case. And how often does one say that? I think at Barrow, where I was for many years, I'd probably say it for every day. Wow. But it wasn't it's not necessarily. I think I say the same thing now with the cases that we see now. I probably say wow every day too. So that was the PAS positive diastase resistant globules, and there were other nodules that showed similar changes. So, for example, here, look at all these. I was quite amazed, in fact, at this case from several points of view. First of all, that she had presented late. Secondly, that I mean, this is a sort of case that I can sort of sympathize you, Gwen. You got a huge workload, got 1,000 cases to get through. It's a Friday afternoon, and you just don't see it. So you've got all these globules, and this is pretty typical of alpha-1 antitrypsin deficiency. Having said that, I saw a child of how old is this kid? 20 months, I think it was. Yes, 20 months on. I think I saw it on Friday last week, and I saw small globules. And the thing is, with alpha-1 antitrypsin deficiency, in the initial phases of life, the globules are very small, because if we just remind ourselves of the pathophysiology of alpha-1 antitrypsin deficiency, what happens is that the genetic mutation, and you all know the various mutations that I always have to look them up, PIZZs and MZs, and Chris, you can tell us, and so can Dinen. But we get the homozygotes and the heterozygotes, and anyway, what happens is that you get a defect in what's called the folding protein. That's the effect of the mutation, and as a result of that defect in the folding protein, the alpha-1 antitrypsin deficiency cannot be exported from the cell, and consequently it accumulates in the hepatocyte. So understanding that then enables you to understand that in childhood, in fact, these globules are extremely tiny, and in fact you may not even see them in the first few months of life. So that's why you've got to do, for example, patients who have neonatal hepatitis, because in children, this can present as a neonatal hepatitis type syndrome. And that's why you've got to do the alpha-1 antitrypsin deficiency, because the serum levels, because you won't see it on histological examination. And I also remember, and I'm digressing a little bit, another case that I was asked to review by one of the other practitioners, gastros in town, hepatologists. And this was a case of a 15-year-old young woman, and she, I looked at the biopsy, and sure enough, there on the PAS diastase stain, there were these tiny globules, and I just want to point out where they usually are. So this is a cirrhotic liver. But if you look, the globules are usually situated adjacent to the fibrous connective tissue or the portal tract. That's where you look for them. You don't look for them in the center of the tissue. You're unlikely to find them unless it's really, really severe disease. And in this particular instance, I think you can see some of these globules in the center of the nodule. But you can see that the sort of gradient of the globules being readily apparent next to the fibrous tissue. Anyway, so I looked at this particular 15-year-old. PAS was positive, and I said to the physician concerned, "Have you done alpha-1 antitrypsin levels?" And he said, "Well, they normally do them." Anyway, it turned out that they hadn't done them. And in this particular instance, this patient that I'm referring to was a heterozygote alpha-1 antitrypsin deficiency, and her levels were low normal. And we picked it up on the PAS diastase. But the importance of it is that the physician concerned obviously then had to go and screen the family because there were siblings. And I think, in fact, everybody else in the family was okay. There was a brother, and I think he was okay. So she was a heterozygote. So it's a disease that can just sort of, creep under our noses. And as I say to all the registrars, it's an important disease because the the genetic mutation, the incidence of the mutation is about 1 in 1,200 to 1 in 1,500. So it's certainly something that one should actively look for. And from a histopathology point of view, you do need to look for it, because if you just glance over it, you'll easily miss the inclusions. The inclusions may not necessarily be seen on the H&E stain, but they are usually seen on the PAS diastase. Inclusions are not always, if they're PAS positive diastase resistant, they're not always alpha-1 antitrypsin, indicative of alpha-1 antitrypsin deficiency. And in fact, this 20-month-old who had chronic cholestatic liver disease, her alpha-1 antitrypsin levels were normal. So we're going to have to think again about that. But I digress. It's an interesting disease. And the interesting thing as well, before I show you the copper, that it is not unheard of to transplant patients and to give them a liver from a heterozygote. And in fact, we had one patient, it was a patient of Ernie Song's years ago now, and she was transplanted for alpha-1 antitrypsin deficiency. At least I think it was a she, I'm not sure. May have been a male patient, may have been a man. But interestingly enough, the levels didn't come up as well as we had hoped. And we wondered, in fact, at the time, whether the transplant, in fact, had been a heterozygote liver. Difficult to prove. We do have the donor liver biopsy, which we could look at from a genetic point of view, but to extract the genes out of formalin-fixed tissue and look for those specific mutations, we decided in the end that it probably wasn't worth it. So that's a little story about alpha-1 antitrypsin deficiency. So those are the PAS-positive globules. And then, interestingly enough, this is the Orcine. And strangely enough, the Orcine was reported as being positive, which indeed it is. So if we go to the same nodule, those are the Orcine positive globules. So if one looks in the literature, in fact, what happens is that you also get disturbed metabolism or disturbed copper metabolism in patients with alpha-1 antitrypsin deficiency. So the globules can also be copper positive. So you can go down the wrong road if you don't pick up the PAS positive globules, because you could potentially investigate the patient for Wilson's, when in fact the patient actually has alpha-1 antitrypsin deficiency. So I thought it was an interesting case. I certainly learned a lot from it. I think the relationship of copper metabolism to alpha-1 antitrypsin deficiency to patients with hemochromatosis, quite complex. And certainly when we get these patients, they don't always read the textbooks, and they always have the last say in their diseases. So 2 interesting patients. Thanks, Dinen. Over to you.
Thanks, Prof. So in the recent transplant-related, especially around the metabolic-associated steatotic liver disease data, they're actually picking up a lot more of these PIMZ mutations, so the heterozygote alpha-1 antitrypsins, because it's now a dual hit hypothesis with a steatotic liver disease, which the actual macronodular steatosis may disappear by the time they're actually cirrhotic, and all you're left with is just alpha-1 antitrypsin globules. But also, they're describing it that there's an increased rate of progressing through the fibrosis stages in people that have the dual hit, either from metabolic-associated, alcohol-associated, or a second hit that are also PIMZ heterozygous for alpha-1 antitrypsin. So it's just being seen a lot more, not because they're actually picking it up earlier. But we've been working closer with the MOPAC heart and lung transplant team. And unfortunately, there's been a few that have been transplanted at a younger age for lung transplants for homozygous and alpha-1 antitrypsin deficiency, who now, many, many years later, are developing significant liver disease from alpha-1 antitrypsin. And now it's a question as to how good are their lungs now, 10 years post-lung transplant, and would you then need a liver only or a liver and a lung together as a second transplant? So it's actually opened up the door quite wide to this illness for us.
Yeah, it's interesting. So in some
Mm.
ways, a bit like oxalosis.
Yes.
Mm.
You know,
So Martin,
yeah, yes.
thanks so much. So Dinen, the point is the heterozygote form can alter the natural, the heterozygote form of the alpha-1 antitrypsin alters the natural history of other forms of liver disease.
Yes.
So that's what you mean by the dual hit.
Yes.
So, Martin, are you able to differentiate so sort of in a heterozygote that has low alpha-1 levels in the serum and say has MAFLD or MASH or whatever, the contribution of alpha-1 antitrypsin to their disease? You know, how will you differentiate a true alpha-1 antitrypsin from an alpha-1 antitrypsin that's just made fatty liver worse?
I don't think we can, Chris. I think that I think you've got to take all those parameters into account. I think that yeah,
Distribution doesn't help you, size of globules doesn't help you.
no, it doesn't.
So
I mean, size of droplets will help if you if we know the age of the patient, because as the patient gets older, the droplets will get bigger in size. So,
okay.
So in this 15-year-old that I was referring to, this 15-year-old young teenager, her droplets were very, very small. And I suspected that because of the size of the droplets, she was a heterozygote, which indeed proved to be the case.
So Dinen, I mean, clearly you're in a tertiary referral center. I mean, you probably do alpha-1 antitrypsin on everyone.
Yes.
Right. So give us your approach to clinicians like myself sitting in an office and seeing a lot of asymptomatic elevated transaminase elevations. Would you recommend alpha-1 antitrypsin in all those patients?
No, so Prof, we generally do it as a 2 or 3 step procedure. Step 1 would be all of your common hep virals, autoimmune hep immunoglobulins, those sort of things. And if persistently abnormal LFTs and nothing hits on the first one, then a broader spectrum of testing. And that's sort of where alpha-1 antitrypsin becomes part of our routine second step of bloods that are done.
With Wilson's and blah, blah.
Iron studies is first line, Wilson's probably second line, but it's sort of just more from a cost perspective, because when I was fresh in the unit, I used to tick all of them off at the first visit, and a patient visited me back to say that it's a 35,000 Rand escapade.
Yeah.
But so we've started staging it a bit, common things occur commonly, and then spread it wider after. But definitely in all of the suspected NAFLDs now, we are doing alpha-1, making sure we're doing alpha-1 antitrypsin.
So what's the pathogenesis of this heterozygote that makes NAFLD worse?
No, it's just a concomitant deposition of these globules together with the fatty liver that seems to worsen the intrahepatic inflammation. And then the more severe inflammation, quicker progression through the fibrosis stages.
Yeah, so Chris, one of the things that I sort of remember that's a clue to diagnosing alpha-1 antitrypsin is unexplained elevation of the ALT. That's supposed to be a clue. Dinen, I don't know if you would agree with that.
Of all my patients have elevated ALT.
That was sort of on its own. So, you know, the sort of patient that comes along and there's just this abnormal ALT, which is not.
Oh, you mean without AST elevation?
Yeah.
Okay.
Yeah, just
It's like, yeah, it's like a low alk phos and a clue to Wilson's.
Since
Yeah, so that's a clue.
Mm.
I think the other thing as well
Excellent.
that we don't really fully understand is that, one of the things that I always teach the registrars, and in fact the students, is that fat in a hepatocyte is really just indicative of a sick hepatocyte. So it's, when the liver cells start to feel the pressure, then they start to be, they lose their ability to move fat in and out of the cell because of the disturbed apolipoproteins and the transport proteins. So it could well be that, when you get alpha-1 antitrypsin deficiency, that if you've got a deficiency in folding proteins and that sort of thing, that it has an effect on that transport. I don't know.
Sure.
Simplistic.
Excellent. So I think the lesson is we've really got to be much more aware of it than we were. And even if you don't pick up a homozygote, if the levels are low, it may be a contributing factor to the, to the present liver disease of other causes.
Yeah. I mean, it's the commonest genetic defect, isn't it?
Mm.
1 in 1,200.
And unfortunately, the new treatments for the enzyme that are directed at the lung, because you've got a sort of faulty production line resulting in a lack of enzyme. That's what drives the lung damage. So they've now formulated the enzyme for the lung damage. So picking up kids at a young age before they develop the bronchiectasis and the sort of COPD symptoms of alpha-1 antitrypsin lung disease with the homozygotes, those are now being treated with a synthetic enzyme. But from AASLD's publication, they don't think that synthetic enzyme actually turns off the intrahepatic stimulation for production. So even those that you manage to save the lungs with synthetic enzyme may still develop liver disease later on, because it's the deposition of the abnormal protein in the liver.
Mm.
Yeah.
Excellent. Thanks, Dinen.
Thank you, guys. I see we are a little bit early, but there may be one comment in the chat box. Oh, sorry, Prof. That was you.
That's it.
Yep. So in closure, I'd like to thank Echo New Mexico, the Echo India team. I'd like to thank Prof. Hale and the Gastro Foundation for allowing us to have these lovely Wednesday afternoon talks. Thank you, Prof, for all of your time, Prof. Hale, Prof. Cassanides, and thanks to all of our sponsors. Next week, Wednesday, everyone will be deciding our country's fate, so we will not have a meeting. So we'll see everyone in 2 weeks' time. Thank you very much.
Thanks, Dinen.
Well,
Thanks, Martin.
next pleasure,
Bye.
guys.
Thank you.
Enjoy it.
Bye.
Cheers. Bye-bye.
Bye-bye.
Bye.